Шановні колеги, шановні
Dear
друзі,
colleagues and dear friends, welcome to our 11th webinar on a track to live with women with HIV, organized by WAVE, which is a part of EACS family. And I would like to thank you very much that you were able to join us today. And the topic of our today's first day is EACS guidelines. And we are very much thankful for translation into Ukrainian, and they're accessible and available to anyone. And also, in the beginning, first, I would like to introduce our wonderful speakers. We will start with our chair. Justina Kowalska is with us today, wonderful, beautiful woman who has inspired all of us to establish the whole series of webinars. And for the first time, it was not just an online webinar, it was a very warm meeting in Kiev, and we all remember it. And we are still hopeful that in the nearest future we'll be able to do it again. So Justina Kowalska is a doctor of medicine and doctor of sciences, MD, and professor of Warsaw Medical University and senior consultant on infectious diseases hospital in Warsaw, Poland, and she is the president of the network of physicians in Central Eastern Europe, ECE. And also, I would like to mention that in the very beginning of war, when the situation was really difficult for us, ECE has provided us a precious support to all of us, and our patients living with HIV provided a lot of, maybe hundreds of contacts, doctors and clinics in Central Eastern Europe who were ready to provide the support to people who were forced to leave Ukraine. Justina, we are very much thankful for that. And Nina Weiss is with us, professor, doctor of philosophy, doctor of medicine from the Hospital of Copenhagen University, and hopefully I have pronounced Vidova the right way, because it's difficult to pronounce that. The chair of infectious diseases from Copenhagen University, Department of Clinical Medicine, Denmark. Welcome and thank you for joining us today. And also, our co-chair also is Svetlana Antoniak. You know her really well. Svetlana is an infectious disease specialist and scientific worker and researcher at HIV/AIDS and Viral Hepatitis Department and Institute of Epidemiology and Infectious Diseases, named after Gromashevsky, Kiev, Ukraine. She is an honored doctor of Ukraine, and we all know that she is among the best, if not the best, specialist in HIV in Ukraine. So thank you, dear Svetlana, for being with us today. And also, I would like to introduce our speakers. The first lecture is going from Juan Ambrosioni, MD, PhD, HIV infectious department unit and infectious diseases in Barcelona, Spain. Also, he is a coordinator of EACS guideline establishment development group. Unfortunately, Juan was not able to join us for discussion today, but there is a good news. In order to answer your questions and to be part of the discussion, Jürgen Rockstroh has joined us. He is a doctor of medicine and head of the Department of Therapy in Bonn University Hospital, Germany, and also he is in charge and he is the chair of EACS guidelines development, and he is one of the most famous and known doctors dealing with HIV infection, not only in Europe but globally. And recently he was the president of EACS in 1920. And Jürgen, thank you also very much for joining us today. Also, our discussion will be joined by Alla Voloha. She is a doctor of medical sciences and professor of pediatric infectious diseases and pediatric immunology of the National University of Health, named after Shupik. Alla, thank you very much for joining us. You're a wonderful specialist, so thank you for your expertise and for your readiness to share it with us today. And the last but not the least speaker is Marina Sira, Doctor of Infectious Diseases at the Department of HIV/AIDS, Institute of Epidemiology Infectious Diseases, named after Gromashevsky Academy of Medical Sciences, Ukraine. And today, Marina is going to present a clinical case about late HIV diagnosis in a woman. So, dear colleagues, once again, thank you so much for being with us. Maybe just a couple of words, and I will try not to take a lot of time. This is just some household issues. So, dear participants, you are participating and viewing this webinar free of charge, and you can share this link to any colleagues that might be interested in this information. And maybe if you don't have the opportunity to join today, or your colleagues cannot join today, it will be possible to view the recording at the YouTube channel. And also, you are an indispensable part, integral part to our discussion as well, because we are very hopeful that you'll be active to put your questions in the chat, and we will do everything possible to answer all your questions. So it seems like that's all. Now I would like to give the floor to our chairs, co-chairs, speakers for welcome. Justyna, if you don't mind.
Дякую, Сергій, дякую, Світлана. То у нас
Welcome, everyone. Thank you, Sergey, Svetlana. This is the 11th webinar.
More or less my Ukrainian so far. But I am going to learn more for sure. And I think it's amazing that we are conquering time and war and any possible obstacles and stay together. Today, we have Nina Weiss and Jürgen Rockstruck strongly representing EACS society, showing that we do care very much about the doctors in Ukraine and also about the patients in Ukraine, as well as about the doctors from Ukraine who are with us here and the patients who came to us. And not to delay the fantastic lectures that we are going to have together today, I'll give words to my co-chairs, and maybe also Jürgen, you could say a word.
Sure. Maybe I can just start just saying how wonderful it is that we have this opportunity to share experiences and interact with each other in these difficult times. And so it's a real privilege to represent EACS and the guidelines here. And I'm looking forward to a very stimulating discussion. I know how tough it is. I mean, we're all trying our best to help all the Ukrainians who have come to care. And it's, in Germany, we also have a really high number and a lot of experience now. So I think there's a lot to share and talk about, and looking forward to spend this afternoon with you and hear what your questions are. Thank you.
And I could also just say I'm very happy to be with you all. I'm vice chair of WAVE, which is Women Against Viruses in Europe under EACS, and it's my great pleasure to be with you today. Thank you.
Що мені сказати так?
So maybe I will be the next to say something, right? So dear colleagues, again, I'm very happy to greet you at our 11th webinar, WAVE EACS, on track to improve health of women living with HIV in Ukraine. Thank you so much for showing your interest. And of course, I understand that you are busy people, you have lots of challenges, still you found time to participate. And for 2 days, you're going to be with us to discuss very important topics of EACS guidelines regarding women and their needs. So traditional, I would like to express my words of gratitude to Professor of Warsaw University, Justyna Kowalska, who is the chair today of our webinar, and together with Dr. of Medicine Caroline Ebipop, who is working at the infectious diseases unit of Bern University Hospital in Switzerland, and she was the head of WAVE at that time, and together with Fiona Mulcahy, Professor Fiona Mulcahy, who works in the clinic St. James Dublin, and he also at that time was the vice president of EACS. They inspired us. So you inspired all our webinars. So since 19, we are meeting very often, and this is the 11th time. We are very happy to see Professor Jürgen Rockström, who is a top specialist on co-infection, HIV, viral hepatitis. Very happy to see Professor Nina Weiss from Denmark, and dear colleagues from EACS and ECE, thank you all very much for your support and help. And regardless of war, we are very much thankful to Ukrainian participants. Thank you very much, because very often we don't have power, we don't have electricity or something else, or there are some alerts, but still we meet on a regular basis, and we still meet on a regular basis to discuss clinical case and so on. And so thank you for joining us, because we care about HIV and providing all other necessary help to people who live with HIV. So, okay, let's start our work. Sergei Antoniak is going to be our moderator. He is a researcher at the clinic of the Institute of Infectious Diseases and Epidemiology. Thank you very much.
Так, Алла Петрівна, теж може декілька слів для наших.
Maybe Allah will say a few words. So I just mention a couple of words about Allah. By the way, Allah was developing a section on children, pediatric HIV, and prevention of mother-to-child transmission in EACS guidelines. So it says Anna Kovals there as member of WAVE, but Allah Voloha was also a member from Pianta mentioned there. So the floor is yours. Welcome everyone. Thank you very much for inviting me. It's my pleasure to be in such a professional and respected company. I remember Jürgen Rockström manuals, so maybe 20 years ago. I remember I've been studying using them. So thank you. I am a member of PENTA, Pediatric Association to Treat HIV Infection in Children. Yes, and I was a member representative in the working group. And yes, I've developed the section on HIV in children. So it was, I was honored to be part of that. And also I'm honored to cooperate with Penta EACS. Thank you. Thank you, Alla. Marina. Welcome, everyone, dear colleagues. To me, it's a great honor to be part of a conference of that level. So I'm very thankful to the organizers for this opportunity. Thank you, Marina. All right, dear colleagues, I think we can go on to start the webinar. So thank you very much again on behalf of all the Ukrainian doctors for your kind words and support again. So we will start our first mini lecture presented by Juan Ambrosioni, and this is about the process, how clinical guidelines are developed, so how it happens. Dear participants, just to remind that you can put your questions anytime during the lecture, after the lecture, and we will try to answer your questions later on. Thank you. Let's start.
Hello, everybody. Thank you very much for the invitation to present this session about the EACS guidelines update process. These are my conflicts of interest. And this is the content I'm going to try to follow for this presentation, just to give an overview of the EACS guidelines content, the updating process, some perspective for the future, and then questions and answers from the participants. So the EACS guidelines is one of the most important activities of the European AIDS Clinical Society, together with a very strong educational program and also the European AIDS Conference. But probably they are related because many of the educational programs are following the content of the EACS guidelines. And also, given the reach of the guidelines, not only in Europe, but also abroad in other continents and other countries, this is probably one of the most important activities of the society. This is the letter you will find in the first page of our guidelines, and they were published for the first time in 2005. And currently in 2023, they are available online as a PDF, as a web version, and also as a free application for iOS and Android devices. And it's important to know that these guidelines are being updating almost all the time, because we have minor revisions annually and then a major revision every second year. But also you may have interim updates when it's necessary. And the most important aim of these EACS guidelines is to provide easily accessible and comprehensive recommendations to clinicians involved in all aspects of HIV care. Something that is also important to mention for the European guidelines is that they cover a relatively large and diverse geographical area in Europe, where the access of health care systems and to medicines in the different countries can be very different. So as a natural consequence of this, these guidelines aim to cover wide range of recommendations that can be opposite to the more often uniform recommendations you may find in some national guidelines. We will see some examples later of this. And so regarding the organization, each respective section of the guidelines is managed by a panel of experienced HIV experts from Europe, but also from the rest of the world, and also with additional experts in specific fields. For example, in the comorbidities from the cardiology part, there are also cardiologists, or not people only involved in the field of HIV. And all the recommendations are evidence-based whenever possible, and based on expert opinions in the cases where we do not have adequate evidence. However, we do not provide the grace of evidence, but we have, of course, consensus within the panel to provide a recommendation. And these are the current chair, Jürgen Rockström, and myself as a coordinator. Something also really important we have to mention about the guidance is that, as you can see, the last version has been published in October 2023, but this last version is already translated into several languages, for example, Romanian, Ukrainian, or Russian, and also many other languages for the previous versions. And this is extremely important because many countries do not have national guidelines for specific conditions. This may be not a guideline for the management of HIV, but maybe not either a guideline for the management of hypertension, and these guidelines are particularly important for clinicians as a tool to manage these specific conditions beyond the management of HIV infection itself. So as I mentioned, we have a major update every 2 years and an organization that is divided currently in panels. These panels are ART, drug-drug interactions, comorbidities, viral hepatitis, opportunistic infection, and pediatric HIV. And each panel is led by a panel chair, supported by a vice chair and young scientist. And as I mentioned, we have a major revision every 2 years, and we present this update in the EACS conference, and also a minor revision every year, usually presented at the Glasgow conference. This is not the work of only one person or two, but the work of a lot of people. Here you can see, according to the panels, all the authors, including the chairs and vice chairs. In the interest of time, we're not going to read the names of all of them, but something very important is we take in consideration the geographical distribution of the authors, the gender balance, but also the promotion of generational exchange, with a very important activity and role of the young scientists, people who is helping with harmonizing all the recommendations of all the experts in each panel and implementing these changes in the final document. under the supervision of the coordinator and the chair, but also very important, we have community representatives and WAVE representative here. As you can see, Anna Koval is the current representative for WAVE, and they are extremely important because they ensure that the content is appropriate from the perspective of the community and women, and they are checking all the content of all the sections in all the panels. I was mentioning before that the recommendations are quite large, opposite to national guidance. This is just an example. This is the initial combination for people who is naive for ART. For the initial regimen, you may start for somebody with HIV infection, and compared to some national guidance, we provide higher number of regimens. If you take a look to the American guidelines or the British guidelines or HESIDA guidelines, which are the guidelines from my country, from Spain, in all these guidelines, we only recommend fewer combinations that are all based in second generation integrase inhibitors, but we consider that in some circumstances, in some European countries, you may not have second generation INSTI, and that's the reason we are providing more options for people in these guidelines. Regarding the updating process, there were many challenges until the last year we were facing with the updating process. One is the length of the guidelines, the other is the complexity, and finally, related to the other two, the logistic of the update. Regarding the length, the version 12.0 launched in 2023 had twice the number of pages compared to the version 9.0 6 years later, and this is because, of course, we had in the middle COVID-19 pandemic and then the Mpox epidemic, and also we have the appearance of the long-acting treatment. So, of course, this is becoming longer and longer and more complex. And this complexity is not only the number of pages increasing every year or every 2 years, but also that you have to harmonize the content between all these sections and panels, making really, really difficult and complex this process. And also, the logistic of this process, I'm going to show you in a second, it was really hard and time consuming. This is a complex overview of the process we were following until 2023, circulating a lot of documents within all these huge number of people I have shown before for the panel members. And then also we needed to typeset the PDF version in August, and then also to produce the years of the mayor revision, a short version of the guidance to be published in HIV medicine. And it was extremely, extremely complex and difficult and prone to error as well. But it's not only the publication of the minor version or the major version each year, but also sometimes you have really important information that you have to share with the users and the people following the guidelines earlier. And then you may have also interim guidance for specific conditions. This one is, for example, the last one very recently published in our page for the use of statins, according to the very important study published, the REPRISE study last year. But this happened also before for COVID-19, for Mpox. And so you have to add all this additional work to the one of the schedule I mentioned before. So it's a really complex process every year. And so sometimes these interim guidance are too long to include all these narratives in the guidance. That's the reason they are launched earlier in more detail. But so I mentioned that until 2023, we have these 6 panels: ART, DDI, comorbidity, viral hepatitis, and opportunistic infections, and finally, the pediatric HIV. This is a little bit of a spoiler, but it's going to change in 2024. As I mentioned, we were following an updating process, including a Word version, PDF, web version, and then the applications. It was really long and prone to errors. But in fact, we used to have the PDF version because until the conference in Basel 2019, we used to have a booklet that was printed. This is not printed anymore, so we do not need anymore the PDF version. And so in 2024, you will not see anymore the PDF version. You're going to see a simpler version of the web version that is going to be easier to find the information, because we kept all the information included in the 6 panel, but rearranged in 2 parts. So now you will see only 2 parts. The part 1 will include all the infectious contents, let's say, for example, the management of HIV, for the management of sexually transmitted infections or the management of opportunistic infections. And then in the part 2, you will see the management of all the comorbidities related to HIV management. That was something requested not only by the users, but also suggested by some of the leads, panel leads in the guidelines. And so now we'll see, hopefully, a system where it's very easy to adapt the content and also to check for the harmonization between the sections. So this is what you're going to see when we're going to launch the new version of the guidelines. You will see only the web version that is going to be organized in one part, the one for the management of the, let's say, infectious processes, the management of HIV, the drug interactions, the treatment of other infectious diseases, and then you will see there the management of sexually transmitted infection, opportunistic infection, immunization, and then the management of pediatric HIV infection. And then in the second part, you will have rearranged all the chapters for the comorbidities: cancer, cardiovascular complications, bone health, kidney complication, liver complication, etc., which will have also have sub-index to check the specific subchapters. For example, in the section 2, you will see diabetes or dyslipidemia or in a specific condition. And also, of course, you will have the respective reference for each one of the parts. So we hope this is going to be an easier way to find information, but also to make it easier for the updating process. And then last but not least, something I think is really important, that was not for the version 12.0, but for the version 11.1. And I think this is a really nice example of the role of the community representatives. They recommend us to remove any abbreviation related to people with HIV because they consider it was not appropriate to refer to people with an abbreviation. And we, of course, we follow that recommendation and we agree with this, but also because, in fact, the whole document is a guideline that is intended to be for people with HIV, and it was not necessary to remember all the time there was ART for people living with HIV. So since the version published in 2022, you won't see anymore any abbreviation referring to people with HIV. And again, I think this is an important role of the community representatives, and it's the same when we talk about the web representative from the perspective specifically for women. So perspectives, with this new updating process, we think that the guidelines are now changing into a living document more than a specific period for release every year. We're keeping for the moment the publication specifically in the conference and then in the Glasgow conference. But of course, if we need at some point to include any really important change, we can do it much more easier because we do not have to wait for the PDF to be ready 1 year later. And also extremely important, an SOP has been developed in 2024 for the roles of the section members, of the section chairs, of the guideline coordinator and the guidelines chair, in order to make it more representative and more transparent and to have the participation of everybody who wants to do it from Europe, but also from abroad. And very soon there will be a call for new members and a selection process to have people who is going to be involved with the guidelines in 2025. So some take-home messages and questions and answers also for our chair later. We think that the EACS guidelines are a really practical tool for healthcare professionals involved in the HIV field in Europe and beyond. There are people from Latin America, from Australia, from Asia using this document, and particularly including places and countries where no national guidelines exist. And this is really important. They provide guidance for every aspect of HIV infection management and consider the existing inequalities in the European countries. So if you see a recommendation that you consider is too wide, then you have to consider also your local possibilities or capacities in your country. And they are regularly updated to provide recommendation based on the state of the art for every topic. And last but not least, community and web representatives foresee all the updating process. So thank you very much for your attention. And then I think you will have the possibility to address questions for our chair. Thank you very much.
Thank you, Juan, for a fantastic overview of the processes. That it's important to underline that it is a lot of work. So it's very important that it is done by many people hands on board. And thank you for underlining that EACS guidelines are living guidelines that are inclusive. They represent the voice of both practitioners, experts, researchers, but also community. And that's the only way how we can represent one voice. And finally, u nas je rekomendacji na ukraińskiej mowie.
And we have recommendations in Ukrainian.
І питання, якщо є питання чи якісь
Okay,
коментарі
thank you. If there are any questions or comments
учасників,
from our
будемо дуже
participants,
вдячні.
we will be very
Дякуємо
thankful.
доктору Амбросіоні, дякуємо
Thank
Юстині.
you,
Я
Dr.
хочу сказати,
Ambrosioni, and
що
thank you,
на
Justina.
цьому
I would like
тижні
to say that this
старшої
week,
клініки
a doctor from our
Анжела Синчук,
clinic, young doctor Angela Sinchuk,
на
as of today,
EACS в
she is at the summer school, EACS summer school in Czech Republic. She is studying there. So thank you once again. And we can confirm, yes, you train our young doctors, and Angela is an example of that. So Angela today is at the EACS summer school. So for the 3 years she was trying to get this, so now she is there. Marina, I think you also were at 1 month training. You can mention that as well. That's true. Absolutely. Yes. It was a short training, and thank you for that opportunity. I've been to Paris for that training, and I've learned a lot of new things. And now we are implementing that knowledge in the work of our clinic. So thank you, EACS, for this opportunity.
Сергій, модеруй, будемо питання.
Okay, Sergey, what do you think? What do we do next? Okay, yes, coming back to questions from our participants. I think we can start from this one. Do you think it is necessary and is it possible to expand the section on sexual and reproductive health, family planning, contraception, PrEP, and so on? Can it be expanded? You mean in the EACS guidelines, right?
Питання до того, хто захоче.
So the question to anyone who would like to answer. Allah, I think maybe it seems to me that you would want to have even more attention paid to women and children, or do you think yes, this is a very important topic. That's true. We have some information in our section, I mean, on prevention, on vertical transmission, but yes, it might be expanded. And considering the fact that a lot of countries as of today is on the track to eliminate mother to child transmission. So in the latest WHO recommendations, actually it was mentioned as one of the 4 very important directions. So I mean the sexual and reproductive health approach and the strategy or the direction for women who live with HIV, and also syphilis and hepatitis B are mentioned there as well. So in order for those women to be able to get all the necessary services, but first of all, it's about women with HIV. So I think it's really important to take all those major recommendations into account with regards to vertical transmission elimination, speaking about HIV and other infections mentioned above. I think it's very relevant. I do not know that maybe the Penta working group might consider some of the advice. Yes, and so I will be talking to my colleagues about that as well. Maybe someone would like to say something, Jurgen, or maybe something else not about this issue.
Yeah, so maybe I can just jump in here. So there's always room to extend content in the guidelines. There always is sort of a balanced discussion because we don't want the guidelines to become too large. You've seen that Juan pointed out that version 9 has only half the pages of version 12. So there is a constant ongoing extension. But in the end of the day, these guidelines are supposed to mirror and reflect all the relevant issues for people who manage individuals living with HIV. So, if that's felt relevant, you can always, even if you're not a guideline member, you can write to the panel of the respective area you're interested in and say, could you add this, or could this be discussed in the panel? And it's given to the panel to sort of decide, do they want to add this or not? And I can tell you that in every version so far, at least the ones I oversee, they always have an addition of new relevant information. And that can be because new issues emerge, like COVID or monkeypox, but it can also be issues like, for example, patient-reported outcomes, where people felt that we also needed to implement this tool and sort of alert people that this exists and so forth. And that was then added in the last version. So you can always add something, and I think all panels are always open for feedback and suggestions.
Well, I would like to add that I second what Alla says. It's very important to include a recommendation for mother-to-child transmission. And to some extent, EACS guidelines have been shaped by a Western European situation where the transmission is very, very rare. And so it is important to keep remembering that there are still countries within Europe that fight and struggle to achieve elimination of mother-to-child transmission. I think we are one of few guidelines that include also a recommendation for the delivery time when there is a very late diagnosis at delivery, acknowledging still a recommendation for AZT in this situation. So it's very important that we have a reference to such a recommendation. Yeah, that's definitely more inclusive, also with pediatrical part on board. And my dream is to expand the section for sexual dysfunction treatment. We do have a section that is quite relevant for men, but we are lacking evidence and good support for women. So that would be my dream, but again, there is very little that can be put into recommendation in terms of valid research.
I would just like to add, and because I'm curious, do you have any idea of how many women with HIV give birth annually in Ukraine? And my second question is, what do you recommend regarding breastfeeding? Are there any women who breastfeed?
Пані Світлано, мікрофон.
Dear Svetlana, please turn your mic on. So previously, there were more women than today, like giving birth to children. But I can tell you, about 1,000 women with HIV last year gave birth to babies. We used to have more, like 1,500, but in 2023, it was 1,000 women who gave birth, women with HIV who gave birth to babies. And more than 117,000 people living with HIV in Ukraine are on ART. So 117,000 on ART. Out of them, more than 50,000 women with HIV out of that number. So a bit less than 50% are women. So this is the picture of epidemic in Ukraine, although among new cases, there are more men. This probably about 65% of new infections are in men, but still we have a significant portion of women. So 50,000 women in Ukraine live with HIV, and 1,000 women with HIV last year gave birth to babies. So just to repeat again, with regards to breastfeeding, we recommend formula, so like artificial feeding, although if a woman wants to breastfeed, and also we have a protocol for vertical transmission as of 2022. That's right, Allah, yes, absolutely 22. And in that protocol there is an indication and contraindications. So when it's possible to breastfeed, if a woman wants to do that, and also it's mentioned there where in which situations there is high risk. So we need to inform women of all risks. Although we understand that transmission via breast milk is not quite U equals U, but if a woman has undetectable viral load before labor and delivery, and so on and so forth, and the nipples are okay, there are no scratches, and they are intact, and so on and so forth. So in principle, a woman might breastfeed if she wants, but in general, we are still like the idea of formula feeding. But if a woman breastfeeds, a woman and the baby have to check their viral load on a monthly basis, which is not possible in our current conditions in Ukraine. Maybe Allah would love to add something, but still we have lots of other problems. I cannot understand why among women who gave birth to babies, 70% of them already knew about their HIV infection. So it's not that their HIV diagnosis was made during pregnancy. No, it was before. But the efficacy and success of ART is very high, and there is 86% of people who are covered with ART and also viral load testing. So it's not 100, but it's 86. It's still high. But in general population, if we look at the general population, failure of treatment, and we use the WHO criteria, 1,000 copies more or less. Yes. So if we look at the general population, it looks like only 5%. Only in 5% we have detectable viral load, but in pregnant women in 20% detectable viral load. So we need to do some studies to understand why is that so. Allah, if you would like to add something, you are most welcome.
Питання дійсно, щоб все-таки в нас
This
продовжувалося народжуватися дітей.
problem is there, so we still continue to have babies born with HIV. Of course, our dream is to have as few babies as possible with being born with HIV, to have the minimal level, less than 1%, just like in Western European, or even zero, right? Yes. But as of today, according to early diagnosis data, it's about 1.5% babies are born with HIV, but part of babies are not tested, still not tested, and later on they present with their HIV infection. And over the last years, we are not able to reach PMTCT less than 2%. So it's up to 2%. So, and the majority of women who have gave birth to a baby with HIV, they know their status for a long time, many years, and maybe the problem is lack of adherence. Also, part of the women are internally displaced people, like internal migrants. So maybe they have challenges and crises in their life, and they forget about therapy, they forget about taking drugs, or maybe they think that everything's going to be okay regardless. So we have to pay more attention. Us infectious disease specialists and family doctors and gynecologists, we have to work together better to be able to keep them under our monitoring, under our attention, to reach undetectable viral load before labor and delivery, and then probably we will be able to decrease the rate of babies born with HIV. That's what I think. Thank you very much, dear colleagues. And we have a couple of more questions in our chat. But considering the timing of our webinar, so there'll be just one more question. It's a specific question to Jürgen, but two other questions will be discussed later on after our second lecture from Justina. If you don't mind, this question is to Jürgen Rockstraw. Do you think it's important to do immunization or vaccination against hepatitis in people living with HIV to use more immunogenic vaccine, Heplisaf-B, that is depicted, that is actually mentioned in current EACS recommendations, guidelines?
Yeah, so that's a great question. I think you're all familiar with the fact that people living with HIV responded not so well to the traditional hepatitis B vaccines. There always was a percentage of like 15 to 20% which developed either no or only very low level antibodies. And there have been two trials with more immunogenic vaccines, in particular Heplisaf, where the ACTG did two trials, one in people in comparison to the traditional vaccine and showed higher responses who were previously unvaccinated, and then also in previously non-responders. And that's obviously the interesting population. And in that population, you saw actually immune responses pretty much in everyone who participated. So the response rates in people living with HIV with this new immunogenic vaccine is, which includes a toll-like receptor antigen in there, is much better. The only problem is that the vaccine is more expensive. So that has led to some issues, at least in Germany. Currently, there are reimbursement issues. But I could foresee that potentially also with a more widespread introduction of this vaccine, that the price will be lowered, and then potentially the uptake will be easier for that very reason. So I think the results are very convincing that there is a better vaccine available, and the question now becomes more, how can we implement that, and also how can price negotiations be performed which allow a competitive introduction of this particular vaccination.
Thank you, Jürgen, for your answer. Dear colleagues, if you don't mind, what I suggest is to switch over to our second lecture from Ms. Justina Kowalska, and then we will continue our discussion and we will answer all the other questions after that, okay? So, Ms. Justina, you're welcome.
So, hello, my name is Justina Kowalska. You know me, of course, very well. And of course, I know a lot of you. I wish we would be together in one room, but unfortunately, we need to continue online. But happy to have all of you with us now and happy to be here for you. I'm going to talk a little bit about the EACS guidelines for women. And very proud that this new version of guidelines, version 12, that we have established for the EACS conference in Warsaw last year, it is also available in Ukrainian now. So I'm pretty sure that you all know them by heart. And I have no conflict of interest to declare. And we start with pregnancy. That's always the most exciting part. So women who plan to be pregnant or become pregnant while already on treatment. So we are talking on women who are under our care, they receive antiretroviral therapy. But let's don't forget, the main goal is still that this treatment is effective. We cannot lose this efficacy during pregnancy. And though we can switch, and it is sometimes even recommended by different guidelines, we need to consider that switch can always bring a change, and this change not always is positive. So for some patients, it might not be a good option. And that's why EACS decides or recommends that this decision, if in case of switching, should be individualized. And most oftenly, we want to switch because we are not certain whether the drugs that are currently prescribed to our patient are safe for the baby as well. So this is this situation in which we need to discuss with a woman, because we want to switch the drug not due to proven toxicity, but due to presumed one, which means that there are no data that this treatment that the patient is currently on is toxic. There is just a lack of evidence. And sometimes this decision is difficult, but the mother's voice, the patient's voice is very important here. So that's how we expect now to do it, a joint decision to be made. And of course, in pregnancy, we would want to monitor monthly or bi-monthly and to have viral load checked every 2 months. But then again, if we have a patient in our care for many years and she's stable on her treatment, we know she's adherent, and her viral load was always undetectable, then we may decide to, for convenience of hers, to do it less frequently. The most important is that we would include week 36 of gestation to have viral load tested, so we are well prepared for delivery. And you very well know that we in EACS guidelines do by examples, by scenarios, our recommendations, and not much has changed here, so I'm not gonna dwell into it for the sake of time. Labor, these recommendations are still stable. We still do recommend in specific situations to have elective cesarean section and also to provide AZT intravenously, sometimes also for a baby if there is nilperose for the newborn. The most important part is that postnatal prophylaxis should be given according to the local guidelines. So EACS is not overruling that part. And a very interesting part is breastfeeding. We start talking more about joint decisions, hearing what women's preferences are, and this goes as well with breastfeeding. As we know, U equals U does not qualify for breastfeeding. So the most important is that we make mothers aware that this decision needs to be made before the baby is born. So we discuss it carefully, and to make sure that mothers understand that although transmission through breastfeeding is low, it not equals to 0. If the mother decides to breastfeed, then we need to make sure that it's 6 months and this is exclusive breastfeeding, which means there is no added, especially solid food, but also water. This sometimes in some cultures is very difficult to perform. But also there are specific situations like refugees, war circumstances, where there is no other option but just to breastfeed. So that's why I think this part of our guidelines is very important, and maybe you might have some questions to add to that, and we are very open for it. And maybe to share experiences, because sometimes nothing is certain and there is no one good solution. Anyways, if breastfeeding is performed, then we need to monitor both the mother and the baby more oftenly. And again, not one solution here, it's 1 or 2 months depending, but again, it's quite intense and it can be quite costly. Nevertheless, the most important part is when the cessation of breastfeeding occurs, that we keep follow-up on the baby and we test the baby with PCR 2 to 4 weeks after this cessation. So I hope these guidelines comes handy and to assist this very difficult process. And as you know, we now also have pediatric part in EACS guidelines and a very nicely written, quite into depth recommendation from our pediatric panel on a page 157. Finally, we want to talk about which antiretrovirals should we choose for a woman who is pregnant but not yet on antiretrovirals. So it's a different decision and not much has changed here in the guidelines. Dolutegravir is still the most recommended drug, specifically because it is once daily, also because it is in co-formulation with TDF and FTC. And also, we now recommend that it could be used with TAF. Raltegravir and darunavir boosted with ritonavir are also good options, but they need to be given twice daily. So the choice here is with adherence and other issues. There is also quite a lot alternative regimens. Those would be the ones using abacavir in a backbone, but also efavirenz, rilpivirine are here suggested. Of course, there are some limitations, but that is well described in EACS guidelines and not much has changed here as well. The guidelines are not only for conception, they are also for contraception. So we put strong emphasis on discussing and providing contraception to women living with HIV who are in childbearing age. And this counseling is also important because they are afraid that the contraception might influence antiretroviral therapy. We are afraid that antiretroviral therapy can also influence contraception and its effectiveness. So it's both ways. Luckily now we have a choice of antiretrovirals that does not have any influence on hormonal contraception. But also remember that one of the best contraceptions is intrauterine device, especially in women who already had children. We can't forget about STI transmission and onwards HIV transmission. That's important. While talking about contraception, we know that sex with condom is out of play most of the time. So let's keep an eye on that. I mentioned drug-drug interactions, and EACS guidelines provide a very in-depth explanation of interactions between drugs. This is thanks to a Liverpool database. It can be also found online. You can see now that most of these interplays between the contraceptives and antiretrovirals is green. So we have a huge choice. If we want to use hormones, we have a huge choice what to treat with the woman. So the choice of contraception is not affected. Menopause, of course, it's a very important part of our guidelines. And the most important is that we educate healthcare providers and patients, that we talk about it, because it comes all of a sudden. You don't suspect it, but it comes, and I know what I'm talking about. So let's use some scales. If it's strange or it doesn't really come as possibility to a woman, we can offer her a self-assessment tool that should be repeated at least yearly and should start at the age of 40, because earlier menopause is suspected to occur in women living with HIV. I would like also to mention that what brings earlier menopause is a shorter reproductive time. So it's very important for our younger patients to make them aware that their reproductive window might be a little bit more narrow than for non-HIV infected women. And then treatment for menopause. Of course, as an infectious disease doctors, we can't replace gynecologists. It's very important that they are on board, but we could always do a little bit, something. And transdermal estrogen creams are a good option to help locally in menopause symptoms. And also the support to anxiety and maybe an onset of depression is extremely important. It's important to screen for that as well. The interactions between hormonal replacement therapy and antiretrovirals are also favorable, so we should not fear that. And finally, to talk a little bit about pre-exposure prophylaxis, and I think that the version 12 is not taking into consideration the newest data on cabotegravir or lenacapavir that are preferentially showing that women can have a successful and highly effective PrEP. But just to remember, when you provide tablets, TDF, FTC tablets for PrEP, women and heterosexual people can be considered, but there is very important part. There no data that on-demand PrEP is effective for women, and that's a major difference. Also, it has been proven that adherence in women, adherence to PrEP is poorer, and thus translates into less effectiveness of that intervention. So I think take-home messages are, as always, we need to assist our patients, discuss with them, and make joint common choices. But the most important, from my perspective as a clinician, is to start talking about what's going to happen on the first visit. So if you have a woman who is not pregnant, not yet planning pregnancy, she wants contraception, let's discuss about this situation. If we have a pregnant woman and she asks about many things, that let's talk breastfeeding with her so she knows what future can bring to her. That's the most important, to bring a solid relation with our patients. Thank you.
Хочу дуже подякувати Юстині.
I would like to thank wholeheartedly, thank you, Justina, from all of us, for this wonderful and very broad presentation mentioning a lot of aspects of helping women in different periods of her life, including the vertical transmission prevention and prevention of unwanted pregnancy, and including other topics, as well as during a bit sad period of menopause. So thank you for that. Really, thank you. Also, I would like to say something about antiretroviral therapy. As we know, dolutegravir and the regimen with dolutegravir in Ukraine is used as a predominant regimen for women, including for women. And I would like to agree with Justina when she said that when we talk about vertical transmission prevention, we have to start talking about that not even during pregnancy, but we have to start at the time when she first time presented in our care, because we will not be able to develop a good communication with women if we don't do that, because because usually we do it during pregnancy and even during labor and delivery, but we have to do it early. We have to start talk to a woman earlier and make joint decisions. And considering the fact that in Ukraine still, unfortunately, we do have the babies born with HIV, so it's not a lot, but still those are human beings, those are people. So we really need to learn more how to do that in terms of how to prevent vertical transmission of HIV. And we have to concentrate on such issues not during pregnancy, but before. So thank you for mentioning that, for focusing on that. Maybe someone else would like to say something. Dear colleagues, yes, you are most welcome to either comment on Professor Justina's lecture, or we can come back to some questions in our chat.
Якщо можна, да, я теж
If I may, I would like to add something. Thank you, really, thank you so much. Very interesting. And I agree with Svetlana that yes, we have to start talking about such issues as soon as a woman presents for the first time in our care, to talk about possible future pregnancy, to talk about adherence, especially adherence during pregnancy, and she needs to be adherent after she has already delivered, regardless of formula feeding or breastfeeding, moreover, and also involving partners to discussions, to providing care, because we need to be very sure that a woman is not gets infected while breastfeeding. Okay, and we know such cases are possible, and some of the babies might be, by the way, infected during the breastfeeding out of those HIV infected babies. So it would be really nice if an infectious disease specialist could pay more attention to reproductive health issues, about prophylaxis, prevention, about adherence. Yes, so talk about ART, adherence during pregnancy. Because maybe women feel okay, and it seems to many of them that maybe they might not need treatment, and they might discontinue. A lot of women still have myths that it might be dangerous to a baby, to a fetus. So we really need to stress, to focus on that, on every step. And all doctors have to do that. Maybe some additional training needs to be provided to different specialists. Maybe more information has to be provided to primary healthcare doctors, to OBGYNs, because a whole team needs to be involved working with women. So thank you once again. Thank you for bringing up such important issues. Thank you, Ms. Alla. And we have a couple of more questions in our chat with regards to PrEP. The first question is, what is the experience of using PrEP in women in Europe in general, and what's the experience using injectables, cabotegravir, long-acting cabotegravir for that in women? And another question that's related, whether PrEP with lenacapavir is going to be considered in the next EACS guidelines. Dear colleagues, who would like to answer first?
Nina, maybe we can ask you for some insight. In Poland, we do not really have experience with PrEP in women. PrEP in general is very difficult to access, and it's mainly men.
And we have exactly the same experience in Denmark and in the Nordic countries. We don't, in general, use PrEP for women. So that's what I can say about that.
So maybe I can add a little bit. I mean, in Germany, it's the same experience. 99% of PrEP users are men who have sex with men. So it's very exclusively used in men only. There are, though, results from studies in migrant women from France, and there are also studies from women in North America, which show that that also seems to lead to protection if adherence can be maintained. Obviously, the introduction of long-acting agents will be a big breakthrough for women living with HIV because of the great trial results. And the question in the room, though, is how is this going to be priced? So the whole implementation of long-acting is a price discussion. because the European agency has already approved cabotegravir for use in Europe, but it's not really available there yet. It's only available in Australia, I think New Zealand, and North America currently. And so it will be a question of pricing. And in Germany, for example, the cost for generic TDF FTC is around 40 euro per month. And so obviously there will be difficulties to get a higher price because the process we have is that you have to show an added benefit, and that's going to be difficult in the context of the study results which are available. And so I think there will be issues around the pricing. No? You may have seen today that the Purpose 2 study, which is looking at lenacapavir in a different patient population, also showed a clear advantage for the use of lenacapavir over an oral PrEP. So I think we're going to see more and more results ensuring that having long-lasting levels are going to add to the efficacy of PrEP regimens, which will help, I think, to lead to the registration of the drugs. But again, the question is, what is the price going to be, and how can we pay for that in the healthcare systems? I think that's the big challenge. No? So I think undoubtedly long-acting will, I think, really allow to broaden the use of PrEP in many different populations, which currently are not very much using oral PrEP. But the question is, how is this going to be implemented on a price level?
And if I can add to that, Jürgen, I must say that even long-acting as antiretroviral therapy is not that much used in Denmark. And that's very much also due to the price. And it's due to the fact that by now we only see patients who we have known for many years who have been completely virally suppressed. Also for many years, we only see them once a year. While if they choose to, or if they are allowed to choose to long-acting, we need to see them every second month. They have to stay in the hospital for a while to get the injection. And there are some other circumstances, and again, very much the price that makes this kind of antiretroviral therapy not that much used.
Yeah, so in Germany, the price is not that different for injectables than for oral therapy. But the issue you raised about seeing patients less frequently is obviously very different if you have an 8-weekly injection. And if you are thinking of very busy clinics, just think of Chelsea Westminster, or where you have like 4,000 or 5,000 patients in care. Just imagine, rather than coming once a year or twice a year, they're suddenly coming every 8 weeks. There's no way you can handle that in a busy clinic. So I think the uptake of long-acting, which has been very different throughout Europe, but is low, is something between 2% and 3% in Germany. And that just reflects that the implementation has been very challenging, although the price of the drug itself is not very much more expensive, or the same price than an oral therapy. But it's kind of, from an implementation level, difficult.
But I think it's important to acknowledge that WHO actually included cabotegravir in the guidelines, and this is because they are trying to negotiate pricing and accessibility for the regions with a high prevalence of HIV. And I must say, in my personal view, in long-acting is the only way we can provide PrEP for women that is effective. And also, I agree that bi-monthly injections are not really preferentially convenient for both patients and services. But if we would move forward with this technology and provide it for each half a year, then for women specifically, we might have an effective prevention method finally. But there are issues regarding side effects for lenacapavir. We need to learn more because people who are sexually active, they also want to stay beautiful and don't have any lumps or inflammations on their belly. So this is extremely important. And for me, the most important part is that it's very difficult to identify women who are actually going to benefit from PrEP. The behaviors are different. It's usually populations which are at risk are usually very difficult to reach with any kind of prevention. So this is a lot to work about. But I would like to hear more from a Ukrainian perspective, because actually in Ukraine you have access to free of charge PrEP, and I know you have quite a population of women using PrEP, especially in Odessa, as far as I remember it used to be.
Дійсно, так. Питання, до речі,
That's true. And the question about the long-acting cabotegravir is relevant. This issue is relevant for Ukraine because on the 15th of August this year, a couple of first patients received CAP, long-acting CAP, as pre-exposure prevention. And with PEPFAR support, as far as I remember, 200 courses of PrEP therapy were procured. So 200 people with HIV are getting this drug as PrEP. That's right. We've done the first step. We understand that 200 courses.
Next seminar, we want to learn from you and to hear your experience. Wonderful. Well done.
Дякую, Юстина.
Thank you, Justina. Thank you. I would like to say that yes, this is just the first step, but we've done it, and we have a standard of care in people with HIV. We've included injecting PrEP for HIV, injectable cabotegravir, CAB, and there is no preference mentioned there with regards to gender and sex, body weight no less than 35 kilos, and age over 18 years old, so on and so forth. So we are very hopeful that we will continue, because we will tell you, we will report to you about this first experience, and you will share yours with us. Yes, and that's true. Tenofovir with like TDF-FTC, we use that, and we've been using that for a long time. And of course, it's not 200 courses. So that how it looks like. So we have both TDF-FTC, TDF-3TC as well, like on a continuous basis and on demand, both. We have these two types of PrEP, and then soon we will be knowing more about long-acting CAB as PrEP. Thank you. Thank you so much. So, dear colleagues, according to our timing, we have to move on. The only thing that before we switch over to discussing a clinical case, I would like to remind our participants that it's true, the recording of our webinar is going to be absolutely accessible to anyone. I think it's going to be available for a couple of weeks, and also to get the certificate of participation, you have to undergo a survey, and it's not a survey of your knowledge, it's a survey of your impressions of our webinar. You will be able to undergo this survey on our website, and it's not only today. You can look at the recording, watch recording, and then undergo this survey. Okay, so dear colleagues, what I suggest is let's continue. And Marina Sira is going to present a clinical case to us. It's a late diagnosis of HIV in a woman. You're welcome.
Dear colleagues, hello to everyone. Let me present to you a clinical case study about a late HIV diagnosis in a woman. Number of people living with HIV in Ukraine and on ART as of the 1st of July 24 is almost 118,000 people. 45% of them are women. The problem of identifying HIV late presenters remains very relevant for healthcare system in Ukraine. Over 6 months of 2024 in Ukraine, there were identified and officially registered 5,500 HIV cases, almost 70% of them among people 30 to 49, and almost 40% at the time of diagnosis had CD4 less than 200 cells per microliter. And also, we have identified and registered 1,587 AIDS cases and 608 deaths due to AIDS-defining diseases. And due to war, access to HIV doctors and specialized healthcare facilities in some regions is absent or limited, or very limited due to being in active combat zone or due to forced displacement of healthcare personnel and patients. Now about Irina's story. Irina is 45, HIV positive since March 22, previously not HIV tested, likely route of HIV acquisition sexual, divorced 10 years ago, former husband's HIV status not known. She has a son, 20-year-old, HIV negative. After divorce, she had several sex partners. Sex was unprotected. HIV status of partners not known, maintains no contact with them, did not and does not use any substances, including injecting drug use, stable employment, had provider-initiated HIV testing. And in March 22, she had acute left side hemiparesis, admitted to neurosurgery. She had cerebral MRI, and perifocal edema and ring-enhancing lesions was identified. And she had rapid HIV testing and was tested positive. Irina was in the active combat zone in Kharkiv region. She was counseled online by an HIV doctor, and the clinical diagnosis was made: HIV infection, clinical stage 4, cerebral toxoplasmosis, left hemiparesis. The treatment was prescribed according to clinical diagnosis: TMP SMX 480 orally daily, 8 pills per day, 5 milligrams per kilo BID per day. And ART is TDF-3TC efavirenz 400 was prescribed. And now we can see her cerebral MRI with enhancement when she was in the neurosurgery department, and that's where the cerebral toxo diagnosis was made. And we can see that in the right posterior frontal area there is a lesion with irregular borders, dimensions 24 by 22 by 24 millimeters, with marked perifocal edema and ring enhancing. And inside the structures of the brain, midline structures shifted to the right to left by 6 millimeters. So TDF-3TC efavirenz 400 was prescribed. In Ukraine, fixed dose regimens are more preferred, like TLD, but TDF-3TC efavirenz 400 is an alternative regimen in Ukraine, and unfortunately back at that time there was access only to that alternative regimen, and all the drugs were provided to Irina via volunteers. And on 29 of August 22, for the first time, she was seen by an infectious diseases doctor specialized in HIV from Poltava, and she managed Irina's HIV disease remotely online. And since May 22, there is no signs of hemiparesis, so she responded to therapy, but she developed new complaints: decreased vision, floaters in her vision fields, sense of having a smudge in her right eye, headache, and CD4 was 4 cells, HIV viral load in plasma, more than 9,000 RNA copies. That's almost on after 6 months on ART TDF-3TC efavirenz 400. And due to the failure of treatment, Irina was referred to the clinic of our institute. She was admitted to our department. Ophthalmoscopy was done, and the fundus examination was done. I'm an infection disease specialist, and I know how to work with fundus camera. And also, we work in collaboration with an ophthalmology doctor, and she is very experienced in diagnosing eye diseases in people with HIV. And we can see that there are lesions in both eyes. And that's characteristic of CMV chorioretinitis. When we looked at CSF, CMV DNA was seen in CSF by PCR, and viral load was 162 copies in CSF. The diagnosis is HIV infection, clinical stage 4, cerebral toxoplasmosis, cytomegaloviral encephalitis, CMV chorioretinitis in both eyes. The treatment was prescribed ganciclovir 5 milligrams per kilo IV every 12 hours. Due to the virological failure, TDF-3TC efavirenz regimen was switched to TDF-3TC dolutegravir, and we didn't wait for the resistant testing results. The diagnosis of CMV chorioretinitis is a clinical diagnosis. It is made on the basis of a specific signs on fundal examination and based on whether there is a response to CMV treatment. Foscarnet is not accessible in Ukraine, so we use ganciclovir or valganciclovir. And as long as our patient had retinitis and her vision was threatened, we started with ganciclovir. And during treatment, we need to monitor renal function and also consider DDIs. The diagnosis of CMV encephalitis is made based on clinical data, clinical picture, and looking at CMV DNA in CSF using the NET testing method. So in 3 weeks of CMV encephalitis and chorioretinitis treatment, we can see lesions with hemorrhages. There are some mild signs of decreased pathological activity. And looking at CSF, CMV DNA was identified. So we continued treatment, ganciclovir IV in standard dosing. In 12 weeks of treating CMV disease, on ophthalmoscopy, so a CMV chorioretinitis non-active form, and no CMV DNA was identified, so she was switched to secondary prophylaxis, valganciclovir 900 milligrams orally once daily, and ART is continued TLD. In February 23, the patient again came to our clinic with complaints of vision, impaired vision, and ophthalmoscopy. We can see active stage of CMV chorioretinitis in the right eye. So we can see that CD4 is 47 cells. On ophthalmoscopy, active form of CMV chorioretinitis. In the right eye, there was a relapse. And again, ganciclovir prescribed 5 milligrams per kilo IV every 12 hours. On CSF, CMV DNA not identified. So when we monitored outcomes in 3 weeks on ganciclovir IV, eye exam, CMV chorioretinitis of both eyes, relapse in the right eye, non-active form. Irina continues ART, TLD, and also she was switched to maintenance therapy with valganciclovir in a standard dosing. Also, in EACS recommendations in versions of 22 and 23 years, there is a section on treating opportunistic infections and COVID-19. And in that section, there is a very clear, concise, but clear information, very helpful to clinicians when to use ART in OIs, and also there is some information on prevention of chorioretinitis disease. And also here we can see main information with regards to treatment and changes in Irina's CD4 and viral load. So we can see that TLD regimen is efficient for her. We can see she is virologically suppressed, and also we can see that her CD4 cell count is growing, is increasing. And we can see in December 23, when her CD4 was over 100 for more than 3 months, the secondary prevention with valganciclovir was stopped. As of today, August 13, 24, viral load, HIV viral load is undetectable, and the number of her CD4 cells is 332 cells. And on the subsequent ophthalmoscopy, we can see there are some pigmented chorioretinal lesions, but with no signs of active inflammation. Cerebral MRI shows that subcortically in the right frontal lobe, there is a lesion that is decreased in size, and after contrast, we can see there is no accumulation of contrast material. She continues ART, TDF3TC, dolutegravir, and secondary prophylaxis of CMV toxo, TMP, SMX, 4 pills a day. Is this a success story? Yes, of course, we have saved her life and vision is saved, but it would be even a better success to identify HIV earlier. Thank you for your attention.
Thank you very much for this interesting case or clinical case presentation. I'm especially happy that you mentioned the way this patient was infected, because even in a country like Denmark, where we have quite easy access to therapy, we have seen women especially who have been divorced and who have had new sex partners, and where it might have been difficult to discuss protection or, sexually transmitted infections, and then they have become infected. So you say that it would have been, I think you have done an excellent, I'm very, very impressed, and a very excellent job taking care of this patient. And both her life and her vision were saved, which is really important. But do you have any suggestions of what you can do, for instance, in Ukraine, to get easier access to testing?
Зараз спеціалісти дуже
Thank you. Actually, expert specialists are working on that, and testing is being introduced to be done on the primary healthcare level. Also, more attention is paid for the subspecialists to offer testing according to certain indications. But in general, my personal opinion that primary healthcare should be more involved. Thank you.
So is it possible in Ukraine to get tested without informing about your identity? Can you make an anonymous test?
Так, можливо.
Yes, that's possible. Yes.
Можливо протестуватися анонімно. У нас доступна ця
That's
функція.
quite possible to do it without identity. This is accessible.
And is that something, is that a possibility or an offer that is very much used?
Дуже що не дуже часто.
Я думаю, що не дуже часто.
I think not very often used.
Тут також треба
Not often used.
сказати про те, що
We need to say here
не анонімно цьому уділяється також багато
also
уваги.
to tell the patient to be tested non-anonymously. We have to pay a lot of attention. We have to spend a lot of time. We have to counsel, to tell her everything about the care, and to counsel what if the positive result is obtained. So I think most patients, they provide their data.
So what about doctors without outside the specialties of infectious diseases? How familiar do you think they are regarding indicator diseases or infections? Is that something that could be improved?
Я думаю, що ситуацію потрібно
I
покращувати.
believe this situation should be improved. As of now, we have training programs to improve knowledge with regards to testing, and the clinic of our institute also is involved in that. So we develop presentations, lectures, educational materials for other specialists, subspecialists, and for primary healthcare physicians. What are the indications, how to assess, how to test, what do you do with the patient like that, where to refer the patient. But I believe regardless, we need to do more in order to motivate other doctors to identify patients. And I would like to add, thank you, Nina, thank you very much for your questions. What I would like to add, as long as Ukraine is still the country of late presenters, and you can see that about 40% of people at the time of HIV diagnosis have CD4 less than 200. That information tells us that we need to look for more efficient entry points. On the other hand, yes, we are talking about primary health care should be involved into testing and care, but still we are concentrating on key populations. I cannot imagine, or it's difficult to imagine, that a family doctor in 10 minutes, because we have the reforms of healthcare and they don't have a lot of time, so they have only 10 minutes per patient. It will not be possible to find out during that time whether the patient who presents is part of a key population or not. So I believe there is a barrier in that, because very often, even if a patient is a key population, they don't think themselves as key population, or they are reluctant to talk about that. But of course, if a family doctor knows all the family for many years, it would be nice if it was so, but it's not that situation currently. So patient just sign the declaration, and family doctors, they want to have as many patients as possible because this is money. They don't have a lot of time per patient. We have self-tests that you can buy in the pharmacy for self-testing, and if you are key population, there are lots of other programs from the HIV/AIDS Alliance, and you can get the tests sent via mail. Okay, so that's why there are lots of late presenters, and it's not easy to identify route of transmission. So we have to talk about entry points, care entry points. But of course, yes, we have to pay more attention to key populations.
Is there room for emergency room testing?
У відділеннях чи швидкі тести?
Do you mean the emergency departments or just rapid tests you are talking about?
No. You know that in England they started to do opt-out testing in the emergency room, and they looked for HIV and hepatitis B and C and found a lot of undiagnosed people, and particularly in elderly and in heterosexuals. And those are often groups which are missed. And taking the epidemiology of your infection, I think that would be in a country with a relatively high background prevalence, I think would make some sense, because you will get, because let's say drug users, MSM, have their own sort of community specific testing opportunities.
Вот это очень хороший вопрос.
That's a really nice question. Thank you for that question, Jürgen. Unfortunately, we don't have the same practice. Our emergency department do not offer testing, HIV testing, but we really need to think about that, because what we say, well, we talk about the family doctors, let them do the HIV testing, and we distribute, for example, rapid tests. But first of all, we have to think whether a doctor has time to offer rapid tests to all his patients, whether he or she wants to offer rapid testing, and especially if we talk about rapid tests for key populations. It's a good thought, a good practice, the one that you've mentioned. Yes, the emergency departments should do that, should offer that, I mean. And for example, the patient that we have discussed, she was identified as HIV positive in the neurosurgery department because of hemiparesis, but doctors were clever enough to suspect HIV encephali, like a CMV because of HIV. So that was a lucky case, and our doctors start to understand better that such, for example, presentation can be due to HIV infection. Thank you for your questions. So maybe more comments that you would like to give.
Yeah, so I would also like to mention co-testing, because offering HIV tests sometimes is quite difficult to digest for people who are not suspecting, or they don't consider themselves at risk. So what we try to do in one of the projects in Warsaw is that we offered HCV and HIV and syphilis test, and we said, you need to do 3 tests. That's the way they are given free. And the intake of tests was really, really amazing. And women 60 plus were the ones who were really happy to do that. So there are sometimes tricks you can use, especially that rapid testing is so cheap, and it can be done by nurse. It's just enough to mention. Sometimes I think we should we should demedicalize to some extent HIV testing, and maybe try to do it more routinely and spend less time on discussions and more time on actual testing. So probably that would be progressing a little bit. Also to mention that all the Eastern European countries and Central Asian countries that I've been working with, and they are amazing in introducing HIV testing in antenatal care. It's like 99%. But what I can see at the same time is they introduce no testing at all for other women, those who are not yet pregnant or that they are no longer pregnant. And this is something that could be done probably through gynecologists. And just to remember, and this comes with a question to Marina from me, is other sexually transmitted infections. Did you test this woman for syphilis, HPV? What are the options for you? Do you have access? Because we blame others, they don't test for HIV, but I think we also don't test enough for other STIs, including hepatitis C, B, etc.
Дякую, Юстина, за питання.
Thank you, Stina, for this question. Speaking about the viral hepatitis B and C, we do testing. We test for syphilis. We have access to these tests. With regards to other infections,
Нам в цьому допомагають гінекологи.
gynecologists help us with that. I would like to add that we are building on and developing multidisciplinary team, and we try to more and more involve gynecologists, dermatologists, other specialists, because we have some drawbacks with regards to STIs testing. We've started to do treponema tests. We have some combination tests, but basically, if we talk about STIs, they are still the area that we need to work better on. That's my personal opinion. But with regards to OBGYNs, here there are also problems. If a woman comes to get antenatal care, very often a woman is just referred for HIV testing without counseling, and the laboratory also does no counseling. So normal good counseling does not exist with regards to informing pregnant women about HIV infection. So even here, there is still a lot of room for improvement. And also we need to work better with regards to other STIs, what we can do better and where we should get help from other specialists. But yes, we have combination tests, hepatitis C, HIV, syphilis, rapid tests are there, we are using them. But again, just as I have mentioned, we still have to do better. It seems to me we are not as good with regards to other STIs. Thank you. My personal opinion. Thank you, Justina, for your question.
I just want to thank Marina once again for a very, very interesting and well presented case. And I think we can all agree that it's a lifelong task to keep everybody informed about the risk of HIV and how to test and both treat and prevent the infection. So thank you, Marina.
Дякую.
Thank you.
Дякую. Дякую, Марино.
Thank you. Thank you, Marina.
Може, у вас є теж декілька коментарів
Ms.
щодо
Alla,
клінічного
do you have any comments with regards to this clinical case?
Ну, насправді дійсно дуже цікавий
In
випадок.
fact,
І
yes, it's a very interesting case.
я теж, скажімо так,
And
не можу сказати, що просто
I
захоплена.
cannot tell you that I'm
Пишаюсь нашими
inspired,
лікарями,
but I'm very proud of our doctors because they really were able to save life to that woman, that they cared, like medically speaking and emotionally speaking. So we can see that sometimes people get support from specialists from which we do not expect it too much to get this care. I wish other patients could be identified also much better. And some children, I would like to say that some children are identified as HIV positive in adolescence. That's when they already have very severe opportunistic infections. So such cases are still there. We have them in Ukraine. Not everyone is alert enough with regards to children who present with severe opportunistic infections. Sometimes we miss such cases. So we really need to be alert, like all specialists need to be alert with regards to AIDS-defining diseases, to relapses. Like, for example, intensive care units specialists need to be alert. Some are, but there are others who are not alert, so not everyone would remember. Like, for example, severe pneumonias, severe meningitis cases happen in different clinics, in different centers. So such patients need to be tested earlier. So yes, our clinical case is really interesting and the treatment was wonderful. And it's really important that doctors know how to use fundus cameras. And I know that more and more specialists learn and know how to do that. And it's expanding. So thank you. Thank you, Ms. Alla. Thank you very much. So, dear colleagues, I'm a timekeeper and we need to wrap up. The only thing I would like to just remind to our participants that tomorrow, Friday, the 13th, yes, it's going to be the second day of our webinar. And tomorrow we are going to talk about standards of care for people living with HIV and women living with HIV. Please join in. It's going to be really interesting. Okay, dear colleagues, just some wrap up couple of words at the end of the webinar to complete our today's work. Who's ready to start?
Юстина, пожалуйста. Или нет, Юстина
Maybe
будет ключевые
Justina?
слова.
Oh no, Justina is going to be the last to to say the final words. Jürgen, if it's okay, can you tell us, do you think that you never regretted being part of that webinar?
Yeah, I think this was wonderful. I learned a lot of new things. First, cabotegravir is already used in Ukraine, and I don't know any other European country where that's being used for PrEP. That's fantastic. And I think this will encourage us to think about implementing the use of long actings in PrEP into the guidelines. I thought that was important. I enjoyed getting feedback on other sections of the guidelines, what you can see improved. I thought the last case being presented was fantastic because I have to say, it's been at least 10 years since I've seen my last CMV retinitis. And I think a lot of clinicians in Germany, at least, are missing the expertise of seeing these things. And so I think it's also great if we could share these clinical cases so everyone is well prepared for these things, because, and also the management was fantastic. So I thought that was very good. And I'm happy to see that despite all challenges, you're keeping up your good spirit and working together and sharing and interacting. And I was very happy to be part of that. Thank you.
I also want to thank very much, on behalf of WAVE, I'm very happy and very impressed to see the work you do in Ukraine, and especially during the present circumstances. I learned a lot about women with HIV becoming pregnant and their children, and I think that's very interesting because for the ECDC, we are writing new antenatal guidelines for screening of women. So I think that's interesting to know, and I think the case and the clinical presentation is forever relevant, that we have to really always think whether somebody can be HIV infected and not, as I think it sometimes happens, there are certain groups where we don't think it's, possible, or it's not the first thing we think. And I think it's really important just to try to, as a healthcare professional, act regarding HIV as you act regarding HBV and HCV, for instance. So thank you very much, and I'm very impressed with you all.
Дякую, Ніно, дякую, Юрген, за ваші теплі
Thank you,
слова.
Nina. Thank you, Jürgen, for your warm words. Jürgen, our colleagues comment in our chat that only in Lviv center, we have 27 MSMs have already received cabotegravir as PrEP. That's Lviv is western part of Ukraine, so 27 men having sex with men already. Ms. Alam, just final words. Yes, thank you. It was really interesting for me to hear all the experts. And it was a pleasure, truly pleasure. Huge work, I believe, is done in our country. It seems to me we are quite successful. So at least a lot of specialists use other countries' experience. Like, I mean, EACS guidelines for us is invaluable document. That's what I really think, and we use it in our clinical practice, and especially having the Ukrainian translation, it's fantastic that it can be used in our practice and spread its use among our colleagues. So thank you really very much to all of you for that, and I think in future it will be even more used in Ukraine. Thank you. Thank you. All right. Ms. Marina, couple of words.
Я всім дуже дякую за таку
I'm really
можливість
thank you to all of you for giving me this opportunity to participate in this webinar, in such an event. Also, I would like to thank EACS. Thank you for Ukrainian translation. Actually, almost on a daily basis, I use the guidelines. It's very concise, it's very easy to use, how to counsel, how to diagnose, how to treat. And also today I understood that I really need an application on my phone. So the guidelines to have as an application on my phone. Thank you. Thank you, Marina. Ms. Svetlana. What I would like to say is just thank you, thank you, thank you. Thank you very much. Thank you to EC, dear EACS group, dear colleagues. Thank you for helping us all the time, that you are making us feel a part of your European family. So thank you. Once again, we will try to do our best and continue to work for the best of our patients. Thank you. And I give the floor to Justina. We love you. We love you and thank you.
Same here, same here. And I want to say that let's remember when we started with the first workshop in much happier times, the idea was it is a forum for exchanging knowledge. And there is so much knowledge I would like to learn from you, from my colleagues from Ukraine. As we already said, must to hear is the cabotegravir use in Ukraine. We will learn from your experience. Also, I would second what Nina said, that we are amazed by how effective doctors work in Ukraine despite a very difficult situation, especially in eastern Ukraine. So I would like to end today by just saying, wy gieroi, my z wami.
Дякуємо вам.
Дякуємо.
Thank you. Thank you. All right, dear colleagues. Thank you very much to everyone again. Dear participants, see you tomorrow during the second day of our 11th webinar organized by WAVE on track to improving health of women living with HIV in Ukraine. Have a nice evening. Goodbye. Goodbye.